Okay, I'm Dr. Norman Wetterau, and I do family practice and addiction medicine in Dansville, New York. And for the last 10 years, I've done really just addiction medicine. I'm a clinical associate professor of family medicine at University of Rochester, and I'm board certified in addiction medicine and family practice. And I'm a former president of the New York Society of Addiction Medicine and a board member of the American Society of Addiction Medicine. So in my job, people come into the office with addiction issues, particularly with opium. And the first thing I do is I look them in the eye and I say, I'm so glad you came to see me. Because a lot of these people have a lot of shame and they're afraid. And I want them to be comfortable and believe that they can get better. And I think that's maybe the most important thing I do. Then we take a history, we take a medical history, make sure they don't have HIV, Hep C, and so on, and talk to them about the situation. And then if it's an opioid problem, I frequently give them buprenorphine or Suboxone, which I can talk about in a few minutes. Now, I then follow up to make sure they're taking the medicine correctly. We look for do they have anxiety, sleep disturbances, mental health disturbances? And I usually work with a counselor. And so we try to get them to really reorient their life, to find fun things to do without using drugs, how to deal with stress without using drugs, and to get non-using friends. Because even if they don't use drugs for a year, if they're not happy with their life, they're not going to do well. But most of my patients are really happy in their recovery. And they stay recovered for years and years. And that's why I really enjoy doing this, because I get to see the changes in their lives. I work with that, and so do the counselors and so on at the treatment facility, an outpatient facility. We try to get them to AA. We try to get them involved in other activities like a fitness club or things that are not drug-oriented. Some of them get involved in art, and a lot of them come involved in churches or religious organizations so that they can really make a new life for themselves. But they may not move, or they may move out of an apartment where a lot of people are using drugs, or some of them, their partner or brother or sister are using drugs. So they really have to leave those people, but they don't have to leave town necessarily. So I mentioned the word buprenorphine or Suboxone. It's something that I prescribe a lot. So buprenorphine is a long-acting opioid, similar to methadone, but there's several advantages over it, over other opioids. First of all, it lasts about 48 hours in your system, and it doesn't give you that rush or that high. But it doesn't make you high at all. In fact, you hardly know you're taking it. Secondly, it's very safe. It's very hard to overdose on it, and it does not suppress your respirations like other opioids do. It does relieve pain, but one of the biggest advantages is after you've taken it, it's tightly attached to the receptor site in the brain. And so if you take another opioid, nothing happens. The other opioid bounces off and goes out in your urine, and you don't get high. So it gets you out of withdrawal, if you're in withdrawal, and it keeps you really from using other substances because they won't do anything, plus you won't need them. You won't have any craving, and you won't have any withdrawal. So that's why it's such a wonderful medication for somebody that has an opioid problem. Without it, the withdrawal is terrible, and the cravings are just unending, and the people, 90% will return to use. But as long as they take the buprenorphine, and they're not going to use, or they might use once and nothing happens, so they just, what a waste of money. And so that's why it's such a wonderful medication to use for people. Oxycodone is an opioid, and if you're going to have big surgery and in a lot of pain, if you have a broken bone, smashed bone or something, it's very helpful to take for a few days, and it will get rid of some of the pain that can be really, really bad. But after a week or two, it begins to have a problem, and the number of people become addicted. And then also people leave it around the house, and kids get into it and so forth. So continuing on the discussion of oxycodone that I just mentioned, when it came out, and particularly Oxycontin, it was a long-acting opioid, and it would last 12 hours. And the marketing campaign was terrible. They said that you're not going to get addicted to this. It was long-acting, And I realized Suboxone's long-acting also, but it doesn't give you the high like oxycodone and Oxycontin did. And the marketing campaign was gigantic, and I remember speaking out against it back in 1990s. I thought it was terrible, but I was politically totally incorrect. He was supposed to relieve everybody's pain. Everybody should be given it, and doctors were being even rated on whether they gave enough opioids to make sure that they didn't have any pain long term, not just for a week or two, but for months, for years. And when you got tolerance, they would you increase the dose, and you increase the dose, and you increase the dose. And that's what we went through for many years. Yes, they were getting rated. When you went to the hospital, they would ask you what your pain level is, 1 to 10. And if you said 6 or above, you're supposed to increase the opioids. And the same thing in the office. And that was part of the Joint Commission, part of the inspection, part of the quality measures that were put in place by the Joint Commission to make sure people got adequately pain treatment. And everybody believed that it was not addicting, except that's not true. I mean, many of us knew it was addicting, but our voices were totally, we could not compete against the Purdue and the manufacturers of this medication. You know, our voice was totally drowned out. They paid big fees for people to give talks, and then if I'd raise my hand, you know, I was put down. And that's what went on. So in addressing the pain issue, I have to say that in the 1970s and 80s, pain was not always treated adequately. And that's a problem. You're in the hospital, you're in pain, and they didn't want to give you much. So there was some truth to the Oxycontin coming in, you know, that we do need to ask people how much pain they're in. But then the Joint Commission, and it actually, I believe, started with the manufacturers of the medicine, said that just like you do blood pressure and pulse, you ask pain. And but not only do you ask about the pain, but you ask on a scale of 1 to 10, what is the pain? Now, I think it makes sense to ask, you know, how much pain do you have? Is it mild, moderate, severe, and so forth? But that number system is it's very subjective. People will say 9, and then they have other pain later that's much worse, and they'll say, oh, that's 20. And it's really hard to tell. So that's what they did, and it was a way to sort of, you kept giving more and more opioids until the pain level was down to 3 or 4. And so we're in the middle of this epidemic, and the overdose rates in the United States are much higher than any other country, really 5 to 10 times higher than many countries, and maybe the second highest is Canada and then Australia, but they're considerably below us. So why is this? Well, part of it was the Oxycontin coming out and the manufacturers pushing for the 1 to 10 scale and asking and all the things that they did to make sure that doctors prescribed in the marketing, which was gigantic. In many European countries, they don't even have oxycodone, or it's just very limited. So that's one thing. Also in the United States, doctors are paid by the visit and by how satisfied patients are. In other countries, you might get a salary or a different way of paying. So here, if you, you know, patients say, hey, this doctor will give you all the oxycodone you want or all the opioids, then that's where people want to go. They want to get that. So that's another thing. Another thing is the advertising. Very few countries in the world are you allowed to advertise drugs on television, but we do that. And we tell you how good it is and how you should have it and how you need to ask your doctor for this medicine. That isn't just true of narcotics, it's true of other things also. And so that's the problem. And then the way insurance pays for treatment for pain is another major issue. Chronic pain treatment, the best treatment is a comprehensive approach where you have physical therapy, you have counseling, you have alternative systems, and you use medications also. But the insurance companies don't pay for this kind of treatment. They pay a visit, you can prescribe an opioid, they pay an MRI, they pay for injections. But if I said, well, you need counseling or a group or you need alternative treatments, it's not going to get paid for. So you come to see the doctor, and I like to talk to the doctor for a patient for an hour. That's what I really need to do to help them understand their pain and work with them. Very little payment for that. You know, they're going to pay just a regular office visit. So I can write Oxycontin in 5 minutes. The patient's happy, and they're gone, and I can see the next patient. So we have a system that encourages prescription of opioids and doesn't pay for other things. That's not the way it is in other countries. And so those are some of the reasons this came about. There's a lot of things in this country that now we're paying the price. Okay, so the question, one of the big issues is, what about people that overdose? What happens to them? What can we do about it? And fortunately, we have a medication, Narcan, which reverses the effect of an opioid. And it goes to the receptor site and knocks the opioid off, and the patient starts to breathe better, and their pulse goes up, and they do well, and they wake up. So this is a wonderful medication, and you can get it without a prescription, and I encourage people to carry it around, particularly if you're on opioids, if you have a family member or know people that are using opioids. Carry it around on you and be available to put it up somebody's nose. You can also give a shot. But the thing that people are going to be comfortable with is the one you can spray up the nose. So that is it's really wonderful. And a lot of people their lives have been saved. However, when they get revived, I would still take them to the emergency room, and then I would try to get them on buprenorphine or Suboxone, because otherwise they may overdose again. And the emergency rooms in this area now are doing a much better job at getting people on buprenorphine right away. And if you know someone that gets an overdose, try to get them connected to that, because otherwise maybe a couple of days later they'll overdose again, and the next time they won't make it. So one of the questions about Suboxone is how long you have to take it. And the fact is, most people are going to take it for a long time. The methadone clinics, and as they say, Suboxone is a little bit similar to methadone. They did an experiment in which after 5 years they took everybody off of the methadone, and it was not good. A lot of people relapsed, and it was sad. Opioid addiction it's in the brain, and it's very deep, and it will come back in many people. So I do not push people off of it. Some people have been on it for years. Now, some people get off of it. If you're particularly going to move, your life is totally changed. You wouldn't have any idea who to even call or where to get an opioid or heroin, and everything has changed. You can get off of it. You have to go through some withdrawal, because it is an opioid. It's long-acting. It doesn't make you high, but it is an opioid, and so you're going to have some withdrawal. So you need a motivation. Why do you want to come off of it? And I don't push people to come off of it. I think just like diabetics are on insulin, many of them are going to be on it the rest of their life, and it doesn't have a lot of downside to the medication. So, but I've had people go off of it that are successful. I had other people that go off of it and they relapsed. And I tell people, call me right away. We'll put you right back on it. And I think that's something a doctor can do. If you want to get off of it, don't be embarrassed. Just call. And so I feel comfortable if they know they can do that. But if they're ashamed or I'm not making it, then they go to the street. Maybe some weekend they get stressed out or something, and then there's a problem. Okay, benzodiazepines are a drug that helps people relax, and it is addicting. If people are already addicted, if they're taking benzodiazepines in the street and misusing them and so on, there's no way I would prescribe benzodiazepines. They need comprehensive drug treatment. Some people are only have an opioid issue, and I can see them in my office with Suboxone. Other people use multiple drugs and alcohol, and they need really a comprehensive treatment program to deal with all of that, and counseling and so forth. So the benzodiazepines, if they're taking them in the street, they need to work on being constant, and we need to give them alternatives for their anxiety. It's not easy to treat. Now, there are patients, though, that have anxiety disorder, and they're taking a reasonable dose of a benzo, and it's working, preventing panic attacks and so forth. And I don't have a problem with that. I'm not excited about it, but I don't have a problem. And I've had people that taper it. I have a patient that came with me on it, and I didn't take them off. And now I think 5 pills a month, just when they're getting a panic attack, they will take one. And I trust the person. I mean, if they're only taking what I'm prescribing and they're taking it only when they're needed, then I think it can be useful. But it's a hard decision for the doctor and the patient. And you need to work with other ways to deal with anxiety also. I think one thing about so many conditions in your life, yes, medicine helps, but that isn't the only thing. You need to, whether it's opioids or benzos or anxiety or depression, people with depression, exercise, for mild to moderate depression, exercise works as well as medicine. And if you do both, it even works better. So that is, there's something to be said about that. Dealing with the whole issue, whether it's pain, depression, anxiety, comprehensive treatment is really what works. So one of the questions about the overdose epidemic is the involvement of fentanyl. And we started prescribing Suboxone, buprenorphine. We also had Narcan and a lot of treatment, and yet the overdose rate did not come down. And one of the reasons is fentanyl, which is a long-acting, extremely powerful opioid, was brought into this country, and it's being sold as heroin, and it's being mixed with things. Even some people mix it with marijuana. It's awful. And it's extremely deadly, and it's very hard to overcome with Narcan. So you may need 3 or 4 shots of Narcan to recover. And that's what's really driving the system and making it worse and worse. But people, I would think if a drug person was selling fentanyl, I would stay clear of him and just get the heroin. But that's not, some people don't think that way. They think this must be special. And so they go get it and they overdose. And it's been a real crisis. So the question is, how much Narcan should you carry around? And I think that if you have friends that are using fentanyl and so forth, you might have, they sell you 2 at once. And that may be enough until you can get the ambulance to come. Or if you want to buy 2 of them, 2 sets, that gives you 4 doses. That would be great, particularly like if your brother or sister or somebody that you're close to. Now, the average person, let's face it, I can talk about carrying some Narcan around, but most people aren't going to do it. And I'll just say to whoever's listening to this, do you carry Narcan? Are you going to go out and get some tonight after you hear this? And I hope some of you do, but you're more likely to buy 1. It's just, let's be realistic. But if you're close to people, buy 2. That would be good. Ambulances should carry more than 1 because they're going to get called. I hope that if you give Narcan to somebody, you also call 911 at the same time. So let's talk about drug courts for a minute, because drug courts have been very successful. To understand them, most people at drug courts, or many of them, it isn't just using drugs why they were arrested, or it may be, but many of them had petty larceny or burglaries, or did things in order to get money for their opioids. Or some of them were low-level sellers and would sell just a little bit, maybe, and to supply themselves. So rather than sending them off to prison, when they come out, they're going to probably relapse. They're given the choice of drug courts, and it's their choice. And they are seen every week, and they're monitored carefully, and they're constantly in treatment. Some of them go to inpatient, some of them do not. And if they are successful over a couple-year period of time, they're released, and I think that the felony is not even on their record. I'm not positive about that. Now, so it is very successful for those that participate. Another thing is, if you mess up on probation, you go to prison. But if you mess up here, then maybe you go to jail for a day or 2 the first time, and then maybe a week the next time. So it's proportionate. It gives you a chance to learn and to change your life without crushing down. So the drug courts, Rochester, one of the first places the drug courts started. And the record is very good. I'm not saying everybody's successful, but a lot are. And but then a lot of counties did not have drug courts. They didn't believe in them, or they cost money and so forth. There was a bill a number of years ago that reduced some of the lengths of time you went to prison for felonies, drug-related felonies, and also requiring that all counties have a drug court. So I was involved in that, and initially the Republicans in the rural areas didn't want that. They didn't want to be easy on crime. Somebody burglarizes, why should you give them a chance? But we made calls, myself and other members of the New York Society of Addiction Medicine, to some of these senators, and we said, these are your kids. These are rural kids that are going off to prison for something that they didn't mean to get into. And it's really true. I saw a lot of kids in Dansville that were good kids. They got into opioids and they began to do the unimaginable because they were in withdrawal, they needed money, and they began to, first they take money from their parents' purse, and then pretty soon the neighbors, and pretty soon they're arrested, and there's felony charges for burglary. But they really were not criminals. And so the drug court was good. And now all the counties have to have drug courts. And we convinced those senators that this is not a piece of radical legislation. It's not letting people off easy. And it's going to help kids in rural areas. So go ahead and support it. And they did. And I felt really good about that. All right, well, so the question is, what's causing this epidemic? So clearly, one of the first things was the introduction of OxyContin in the 1990s and the promotion of it by the drug company. And then the next thing was the fact that everybody should be given adequate pain control, and the definition of adequate pain control was the problem. It wasn't like, how are you feeling? It was your pain 1 to 10. And then pushing more and more opioids, and particularly for chronic pain when they are not that useful in chronic pain. So that was the start of it. Then the fact that the insurance companies would not pay for what really works for chronic pain, which is comprehensive pain management with alternatives and many different parts of it. So they'd pay for the doctor to prescribe the opioid, but they wouldn't pay for counseling or anything else, and they still don't. So that was another major thing. So then they would prescribe, people were prescribing opioids, but we know for chronic pain, the comprehensive treatment is what works, including counseling and alternative therapies. But they wouldn't pay for that. And they still don't pay for that. So the doctor, the only choice they had was to do nothing, or to give them OxyContin or morphine or some kind of an opioid. And so they would go ahead and prescribe opioids, and if the patient pain was no better, and in like chronic back pain, it frequently wasn't better, then they would increase the dose, and they would increase the dose. Then the advertising in TV was a problem. And then another problem, not only were doctors being rated by how well they treated the pain, but they had required courses that you had to take for your license about how to treat pain. So every doctor had to be told, increase the opioids, prescribe the opioids, and that was amazing. They didn't have any required courses on what addiction was. They didn't have any required courses on the use of buprenorphine, only in the use of opioids. And doctors are not required to know how to prescribe buprenorphine. They're not required to do that. There still is a lot of emphasis on opioids, and it has to change. It's really sad that we got into this. Really, it's big business. And the addiction problem is frequently driven by business, whether it's by the alcohol industry, the tobacco industry, the opioid industry. And I guess we didn't vote to legalize marijuana in this state, but that's the next industry that's ready to push the envelope more and more.
Out of fear.
Okay, so the question is, when they were pushing for adequate pain control, and you had to ask patients on 1 to 10, were doctors afraid they would lose their license if they didn't prescribe enough opioids? And I think that some doctors might have done that. But I don't know that that's necessarily true. There's ways to write notes, interacting with patients and so forth. But if you're only going to spend 5 minutes with a patient, the easiest thing is to prescribe the opioid. Or now it's the opposite. If you're only going to spend 5 minutes, don't prescribe anything. Well, that's not adequate either. And doctors were losing their license for prescribing too many opioids and for not prescribing enough, but not many. It was pretty rare for that to happen. I think that the fear was greater than the. Okay, so I've talked about the treatment and how I see patients. They come into the office and how I get them on medication and counseling. But the American Society of Addiction Medicine defines addiction as a brain disease, also psychologically, social, and spiritual. So the brain part is taken care of by medication or by withdrawing, if it's like a benzo or something, and by treating, if it's opioid, treating the pain in different ways, putting them on a buprenorphine, if it's anxiety, giving them something other than benzos, whatever. So that's the first part of the treatment. But it's also a social. So you need to find friends that don't use and to find activities that they don't use. And that's sort of hard for people to do when the last 5 or 10 years of their life they've only been oriented to drugs. So that's the second part. And then the spiritual part. And if you go to like AA or NA, it doesn't have any particular religious belief other than the higher power. But that's a useful thing, and many people in recovery become involved in churches, synagogues, or other religious organizations that are supportive. And there's a lot of shame. And I think one of the things that I emphasize to my patients when I talk about the spiritual is, at least from my understanding, is God is forgiving, God loves, God forgives, and God can help people change. And so that's sort of my summary. And I think that that's part of the AA thing too. Turn to a higher power, list your wrongs, seek forgiveness, seek amends, and then go forth in a new life with your community. And that's very freeing. And when people do that, many of the people are, I've never been so happy in my life in recovery, because I was able to come through this and solve this. So the question is, what is not working? Well, one of the worst things is when people come to the emergency room with an overdose and they're just sent home and they're not connected up with treatment or with buprenorphine. And it's unbelievable. You know, if I came to the emergency room with chest pain, I would be admitted probably and have an angio catheter. They would have checked me completely. They would just send me home. But if my grandson came to the emergency room with an overdose, in many areas they just send him home to overdose again. Now, that's unacceptable. Then another thing is the treatment facilities have to be, you need to be nice to the patients. You need to listen to them. You know, you may not agree with everything they say, but listen to them and let them know that. So that's important. As far as jail goes and prison, that is not always helpful. I think we should try to minimize that and use alternatives. However, you know, many of the people, it's not just selling drugs, or they're selling a lot and they're making a lot of money. They're driving around in their Mercedes. You know, society can't just do nothing about that. But and some of the crimes are more major. But I think that we should try to decrease the use of prison and have as many alternatives as we can for a lot of these offenses, particularly when they're addicted. So one of the questions is, where do you get drug treatment? And first of all, you can go to an AA or NA meeting to start. That's not treatment, but you can become involved and they could tell you where to go. There's a lot of numbers that you can phone in the phone book into different treatment centers. So in Rochester, you have Strong Health, Unity, Huther Doyle, you have CASA down here in Livingston County, and down in Steuben County. So there are a lot of drug outpatient programs that you can go, and they can put you on medication, they can treat you, counsel you, and so on. Everybody doesn't have to go to an inpatient program. A lot of people want to go to detox. I would say the first thing is to contact an outpatient program and see what level of care they think you need. You could be detoxed as an outpatient in many cases. So call the number, connect, and then they would place you maybe coming once a week, maybe every day, maybe inpatient. Some people can be treated by their primary care doctors, and particularly if they're interested in it. And part of my job as a faculty in family practice is to teach residents about that. So they could detox through the office, prescribe buprenorphine, gets counseling and so forth. So that's another option, depending. If you have a huge problem with multiple drugs, they're going to refer you to a treatment facility. But if your only problem is you binge drink sometimes, they probably could help you with that. Or if your only problem is you are on opioids for pain and you're taking more than you should, but you haven't taken anything else, you're not injecting heroin, you're just a little bit out of control, they can put you on buprenorphine, Suboxone, and maybe that's all you need. You know, you still have all your old non-using friends. So there's a spectrum of how much you have to change your life. And that's, so from primary care to outpatient to inpatient. And if you see one, they can sort of direct you. I'll certainly say, hey, I think you need outpatient, or would you like to go inpatient? And particularly if you're not doing well, or your life is just in chaos, you're homeless and so on, inpatient can be a great relief. So the question is, where do we go forward from here? I think that making sure that the insurance companies really promote treatment, pay adequate amounts of money to doctors that are treating chronic pain comprehensively, and also paying doctors that are prescribing buprenorphine money, so that the time, it takes time to really do this well. And so I think the insurance companies could do a lot in not just harassing us and say, we won't pay for this, we won't pay for that. There's been a lot of legislation that's passed to provide more funding for treatment in this state and in other across the country. Actually, there was a bill passed in Congress that only had 6 negative votes combined in the Assembly, the Senate, and the House. And this is a Congress that couldn't agree on anything, but they all agreed on that. And they expanded the number of people that could prescribe buprenorphine, and that was a part of it. And large amounts of grants that are coming in to even to New York State to provide more treatment. So that's been very, very helpful. So we need to continue that, continue the support, making sure the insurance companies pay up their fair share of what's going on. And then I think that the legal issues as far as prison and drug courts can be tweaked. That's a long subject. It's hard to know what. I think one thing is people in jail should be able to get drug treatment in jail. And before they get out, they should be connected. They should maybe be given buprenorphine or another Vivitrol, which is a blocking shot, before they leave, but connect them so that, imagine the day you get out of jail or the day you get out of prison, that very day you're taken to a treatment facility. Even a better thing is when you get arrested, rather than being taken to the jail, how about taking them to a treatment facility? That would be a great thing. And that's being done, actually, some of it. It's some of it you need laws changed, and some of it you just need to change the way things are done. And so those are a few ideas that I have. So one of the questions is, what about laws to allow involuntary treatment for drug addiction or alcoholism? And that is a very tricky question, because our society is very careful about committing people for medical treatment, even if it's necessary. Even if you're suicidal, it's only like 3 days, and 2 physicians have to sign the paper. And but if you're going to kill yourself by overdosing with drugs, they really can't commit you for that. You have to say, I'm planning to do this. And so I think that we should look at those. And we'd have to get lawyers, and I don't think they're going to pass. But one of the things, what about children? Could that be done? And I think we need to have a dialogue, an open discussion on this issue, because we do send people to jail and to prison, but we don't send them, we can't compel them into treatment. So how do we have a spectrum? And how is there a group of people that could be committed rather than as an alternative to jail? And in a sense, that's already happening. You can go to jail or you can go to this treatment. But then you have to get them arrested. So you're saying, well, is there some other process? And I think we could look at that. And there are informal processes where the police arrive. Even for a mental health arrest for suicide, you have to get the police involved or psychiatrists involved. So there's informal systems that, you're going to get arrested, you're going to go to jail, but if you go to this treatment, you won't. So that's something that's already possible. But changing the laws, I don't know. It's something that the lawyers are going to have to look at. But be careful. We don't want to lose human rights. You know, it's a two-edged sword. So we've been talking about chronic pain. And a lot of the chronic pain, and particularly back pain, is connected with workman's comp. And studies have shown, actually, that recovery, the most important item in recovering from chronic back pain under workman's comp or under anything is how much you like your job. So if you have an employer who tries to make modifications, you don't need to do any lifting, just come and see, just encourage us. We want to be part of it. What can we do to help you? Calling and checking on you. And then making sure that you get the physical therapy you need right away. And these kinds of things. These people tend to get better. Unfortunately, a lot of workman's comp insurance carriers want to save money by not allowing physical therapy, by not allowing x-rays, and by making it difficult for the doctor. And the companies that choose these carriers are somewhat the same way. You can't come back to work till you can do everything. No, you're not getting any disability payment. No, you're not getting anything. No, you can't have an x-ray. No, you can't do this. And that makes you depressed and hopeless. And these people do not get better. And in my primary care practice, when a patient came in with a work injury, particularly back pain, I could almost tell on the first visit how many would be disabled a year later and how many would not, by their attitude and by where they worked and how they were being treated. And so that is a real problem. When you're treated nicely with chronic pain, when your family encourages you, your boss, everybody, you frequently do well. Look at when you did sports in high school. If you had a coach that just encouraged you, yes, and made the practices and what you were doing to where you were, and the whole team was behind you, you got better. And it's a real problem. It's a real problem. That's why I love to get people in AA and NA and different groups and sports and recovery. Recovery is, those, so you feel support. Maybe you wouldn't have gotten in this situation if you felt support. Maybe yes, maybe no. So the question is treatment beds. And I'm going to say, first of all, that rather than beds, because we think that treatment is all inpatient, how many spots in outpatient programs, how many doctors prescribing buprenorphine? We would like people that need buprenorphine to be able to get it within 24 hours, particularly if they overdose or they have a heroin problem. There shouldn't have to be waiting lists. Now, that has improved a lot in the last year. It used to be you'd wait a month. Well, by that time you'd be dead or more heroin, or you changed your mind. But people, they're on the addiction, and then they get I think maybe I should get off of it. And when that thought comes to their mind, they need to be able to go to a place and get help right away. Now, Rochester's improved. They have a number of programs that you can check in on any time, and you can't necessarily get buprenorphine within 24 hours, but it's getting better, and you might get it. So that's really important, increasing the number of physicians that are involved, the number of outpatients, getting primary care to at least get involved to some degree. You're not just saying, we don't deal with this, I don't know anything about it. At least to talk to you and to connect you with somebody within that day or the next day. So that's the most important thing. Now, what about inpatient beds? Personally, I think that inpatient is overdone. I think that recovery is something that happens in the community. You need friends that don't use, you need AA, you need these things. And so I really tend personally to favor outpatient, maybe outpatient with supportive living or places that you can live. A lot of people go to inpatient because they are homeless. So if we had, we need a whole creative assortment of activities. So do they need a place to live, or do they need intensive treatment for 12 hours a day? Some people do. And there probably is need for more places. A place just opened in Dansville, and it's been open like 3 weeks and it's filled. So there is a need. But I've also seen people that are sent again and again to inpatient treatment, and they come out and they're not connected to outpatient. There's no phone calls made, there's no connection, and they relapse 6 months later, they go back into inpatient. And we need to make sure our treatment is good. One of the new things we have are called peer counselors. And so they will take somebody in outpatient and take them to meetings and call them every day and visit them. These are people in recovery themselves. They're really great. I think they do more good than I do. As a doctor, I mean, we work together. They wouldn't say that. They think I do more. We work together. And so those peer counselors are going to help them every day. What are you going to do? How are you going to stay away from drugs? What kind of, and then what kind of housing? Where are you living? What's going on? And they really help you with that. You can go off for 30 days inpatient, and you come back, nothing's changed. Now, don't get me wrong. I refer a lot of people to inpatient. They're just in chaos. And we probably need more beds. But we need, even more than more beds, we need more outpatient facilities and care and people working in the field. There's also a shortage of people in the field. So we really need people to get trained and to go to work. And it's hard work. It's very satisfying, but it's hard work. So what about the opioid epidemic and medicine? The primary care for a long time ignored this. To be honest with you, 10 years ago, we asked the National Academy of Family Physicians, New York State did, to get involved in buprenorphine, to put somebody on the advisory committee, and to increase education on addiction. They did not do it. They absolutely would not. Now they have, so I want to give them credit. And I got to tell you, other organizations, not just family doctors, I'm sure it's the same thing. So I don't want to pick on my own specialty. There's others too. But medicine didn't want to deal with it. Medical schools didn't want education. So that is a problem with the medical profession. Now things have changed. Now, what about mental health? Well, to be honest, psychiatry for years did not want to talk about addiction. Now that's changed, and they have addiction psychiatry. People just didn't want to deal with it. And so we had the drug companies pushing the OxyContin, we had the other things, and now people are starting to deal with it. But we still, not as much. Medical students get much less education in addiction than they do in most other areas. A lot more on skin diseases, a lot more on almost anything. So we need to increase the education. We need to get doctors. We need to get mental health people involved. Now, on a positive note, you talk about behavioral health, which is sort of a combination, social work, mental health, addiction, and they are trying to bring these together. And so some of the primary care practices in Rochester, through grants, are actually bringing these things together. And you can, and they will treat you right in your primary care. And if you need more treatment, they'll send you to an outpatient, which is specific chemical dependency, or maybe it's mental health, a halfway house, or a day program for mental health. And then if you need inpatient, you can go to inpatient. So you have these spectrums of care, but we need to get personnel and we need to get mental health people in primary care that feel that addiction is part of what they do. You can't just push it under the table. We've been doing that for years and years, and it doesn't go away. It just gets worse, and it gets worse, and it gets worse. So one of the questions has to do with harm reduction and needle exchange. And I'm very much in favor of the needle exchange program. I was head of the state medical society's alcohol substance abuse committee when that came to us years ago, and as doctors, and we said this is a good idea. So we were one of the first states to do this. When people exchange needles, they don't get HIV, they don't get Hep C. It keeps them much safer. Now, I don't think it encourages anyone to use drugs, and people are going to share needles anyway. So that's my view. Now, is there any possible downside? Yes, but I don't know that. I haven't talked to patients that said, well, I went and got into drugs because of a needle exchange program. I really don't. I haven't. They don't even use needles from the needle exchange the first time. They usually borrow a needle from somebody else or something. So the question is about reducing needles in the ground is a harm reduction, and that's a problem. But I think it is true that if they share, you got to balance. If they share needles, then there'll be less needles in the ground. But then there's going to be more HIV and Hep C. So that's a problem. So what do you do about all the use, and where does that take place? Now there is a solution, which is quite controversial, and that's the place that you can go and shoot the heroin. And that's a tough call. I'm not totally against that if, and this is a huge if there's counselors there and they prescribe methadone, buprenorphine at the same place. So you come in to inject yourself and they say, well, that's fine, but you got to buy the stuff, you got to hassle. Would you like to try methadone and buprenorphine? Why don't you skip your injection today and we'll put you on buprenorphine? How would that be? Would you like to try it? So in that kind of a setting, it might be helpful. But a setting where you just come in and you bring your heroin and they say, this is fine, this is wonderful, I'm so glad you're here, I have a little problem with that. So it's something our state's sort of struggling with. And I hope if they do adopt it, that it's really connected with a comprehensive treatment and not just total harm reduction. But it is harm reduction, and it does get needles off the street. So the question is what's going to happen to this epidemic? I thought that it would slow down several years ago with the buprenorphine and all that, and it has not. I didn't anticipate fentanyl. The fact is, in spite of all the overdose deaths, new people are turning to heroin. New people are turning to opioids. And there's also a huge increase in suicide among young people. And that's been a problem. So we have a lot of different levels of issues that we have to look at. I'd like to think that it's going to start coming down shortly. But I don't know. We have to get a handle on, I think, legally how we can stop the fentanyl, if that's possible. Can the drug community themselves come out against the fentanyl? So far, they haven't done that, which I find amazing. But I'm not an addict. I treat them in that and when they get in recovery, they find it amazing too. But why the drug community just allows people to sell this? They could say, we're only going to buy pure heroin. We're not going to buy this. But that isn't what happens. So I think, I don't know. It's a tough call. So what about if you have a family member, a friend that's in addiction? Listen to them. I'm sure they have a story to tell. Ask them how they feel about it, whether they wish they didn't have to use this. Did they wish they never started it? And listen, too. Don't just say, you have to get straightened out. Many of them would say, I don't want to get better, but say, do you wish you never started? And a lot of them would say, I wish I never started. And then after that, you say, well, do you believe there's any hope? Do you believe you could get better? And if they say yes, then say, well, how about it? We can get you help tonight, tomorrow. I know somebody that's really good, that's kind, that's going to take care of you. And let's go to this facility or that. So I think asking questions of people rather than lecturing them. Are you happy you're in this state? I'm sure after they use it, they're happy, but are they happy? Is their life in general? Do they wish they never got into this? If they could change, would it be possible to change? And then get them help and make them understand that they don't have to go to 3-month inpatient. They don't have to do this or that. They can start with buprenorphine, and you can ask them what they've heard about it. And many of them have heard pretty good things about it. So then, well, what about you? Would you like to get on it? And then you say, well, listen, the next time you're in withdrawal, you don't know what to do, I'll take you over to the CASA program and we'll get you started. Just give me a call. We're around for you. And they may not be ready that day, but they might be the next day or when they run out of money or something. So they understand they have a choice. And that can be helpful. Yeah, so the question is, what do parents do when their kid is still using drugs? I think that it depends. This is a very difficult thing. I think if they're underage, you should take them to a treatment against their will, and you have some control over them. When they're adults, you should not enable them. I've seen too many parents enabling them, giving them money, bailing them out of jail, bailing them out of problems with no conditions. Now, you can certainly try to work with the jail or prison on getting them treatment, but don't just bail them out and let them continue as they have done. And maybe at some point they shouldn't be allowed to stay at home. That's difficult because they might be homeless, then you blame yourself if they overdose. But I think getting the family to talk, getting people, becomes also complicated if you have different siblings. If you have a 24-year-old that's using and a 17-year-old, and another 24-year-old's giving to the 17-year-old, I think the 24-year-old should be out of that house. That's my personal And they have a choice. You can get them in a halfway house. You can offer them, don't just say the street. We have this treatment, they're going to get you set up in a place you can go, an inpatient, whatever you need. So you give them a choice, but if they don't choose that, then it's going to be the street. And let them know they can call any time and we'll get you into help. We'll get you treatment anytime. But we're not going to give you money and we're not going to bail you out. So you need to be kind but firm. Well, how do I deal with parents who lost somebody? And I just provide sympathy. We've had some candlelight things, I think, remembering. And I usually try to get people in recovery who knew that kid to go talk to the family and just keep them in contact. And I let them know that there's other kids that die of fatal diseases. Now, if they've been in treatment before, I will look at the good times. And I say, he went for 2 years and he didn't use. And then he slipped up and he used. And I said, I think we need to think about the 2 years he wasn't using. It's like someone that has cancer and they have a remission and then they have a relapse and die. So I sort of talk that way to the family. And but it's sad because we know that the person with cancer, there was no choice, and we know the other, maybe there was, but we have to be glad for those days that we had. Remember what they liked before they used. If they got some treatment, remember what they were like. And that's all we can do. The New York State legislators, first of all, so what about the New York State legislators? What would I say if I could talk to them? Well, I do talk to them sometimes, and I'm going to be writing some letters thanking them for some of the things they've done. And the same thing of our congressmen. They've done some good things, and we want to thank them for that. We want to work going forward. Now, in the state of New York right now, I'm going to be writing letters to some as far as the marijuana, actually thanking them for not passing recreational marijuana, but also thanking them for further decriminalization. That let's work together and not lock kids up for possessing marijuana, but giving them a small fine and trying to get them into some treatment and keep them from getting worse. And we need to work together on this. So I'm going to say that some people would not agree with me. Some people would say it should have been legalized, and other people might even say they should not have decriminalized it further. But that's where my position is, in the medical society too. We were vehemently against legalization, but we were, and we believe that it will lead to other drugs and to all kinds of other problems, as it has in other states. But we were actually in favor of getting rid of the criminal records that a lot of people had for possession of small amounts. So we think that was a good compromise. Probably both sides feel like no, for different reasons, but this is the middle ground. In a society that we're having trouble getting middle ground in our society. Yeah. So how can people, the question is, how can the community get involved? Many communities have prevention programs. And so people listening to this, you're in the community, let's say you don't have any family members, you don't have any connection, but you know it's a problem. How could you get involved? I think, first of all, letting your legislators, thanking them for the support they give, the money they give. Call the insurance companies and say you should provide more support and better. Good luck in getting a hold of somebody on the phone, but you can send some letters to the president. That might be good, or the insurance company. There are prevention groups all over, and you'd have to go online, but mostly aimed at youth drug use. So CASA here has programs for kids, but they also have parent groups. And the parent groups are involved with providing drug-free socials, providing support for kids, taking kids, young people that are in trouble, and helping mentor them. So one of the things that churches can do, not just have, we have a youth group with a youth pastor, but what about adults that care about kids and listen to them? If you have kids at your home, having people over at the home that don't use, and providing fun and alternatives free of drugs, listening to kids that have trouble and getting them help. These are things that people can do.